Next slide, please. So the agenda for today will be, we'll have a presentation which is going to last 30 minutes. We'll have a discussion for 35 minutes and closing will be for 5 minutes. So before we talk about the hypothermia, let's talk about the normative. The vital signs of a newborn is a bit different from older infant and children. So let's talk about the normative. On the hemodynamics, the heart rate, the normal heart rate ranges between 100 to 160 beats per minute, and the urine output should be 1 to 3 ml per kg per hour, and the capillary fill time should be less than 3 seconds. And BP depends on the gestational age. For preterm and term baby, there is a different curve, so you can refer from that. On the respiration, the saturation level should be between 90 to 95%, and the respiratory rate ranges between 30 to 60 breaths per minute. And sign of respiratory distress, we usually use a modified Down score or Silverman-Anderson, so that it will help us to assess the respiratory distress condition relatively with objective type of evaluation. So it's better to use Down score rather than saying mild, moderate, severe respiratory distress. When we come to the temperature, the core temperature ranges between 36.5 to 37.5. This is a normal range. On the feeding and growth part, the amount of feeding has to be provided according to the guideline, and kind of feeding, whether it's formula or breast milk, has to be mentioned. And based on the tolerance of the baby, the feeding can be escalated. In the stool, whether it's a blood stained or a normal stool, should be assessed. On the growth, weight, length, and head circumference should be evaluated. Weight should be taken on daily basis, and length and head has to be measured on weekly basis. Next slide. So when we come to the monitoring frequency, in the base setup, and especially in neonatal ICU, continuous monitoring should be provided. If not, then for those who are very critically sick babies, continuous monitoring is mandatory. When we come to the intermittent monitoring, for those who doesn't have continuous monitoring, at least every 2 to 4 hourly vital sign should be taken. If the baby is critical, maybe every 13 minutes or every 1 hour should be taken. Next slide. So monitoring recording is very important. All monitoring should be recorded. The nurse in charge must record monitoring in case sheet and monitoring sheet. Changes in therapy must be recorded because this is very important for the management of the baby. Next. Monitoring for danger sign is again another important area, because if the health worker are aware of the danger sign, then it's very easy to pick problem timely. So when we come to the thermal care, both hypothermia and hyperthermia are a danger sign, so it should be notified early. Feeding, intolerance, abdominal distension, absence of bowel sound, tenderness, and bleeding in the stool has to be monitored very carefully in case the baby develops necrotizing enterocolitis. These are very informative informations. For metabolic, hypoglycemia, jaundice are very important. On the respiratory system, fast breathing, chest indrawing, apnea, cyanosis, low oxygen saturation are very important. These are included in the Down score. So once you start to use the Down score, all these parameters will be included in additionally respiratory should be added. There are 5 parameters to make the Down score. So this is very important. On the circulation, tachycardia, bradycardia, capillary fill time should not be more than 3 seconds. The urine output, the blood pressure also has to be measured. On the neurologic sign, any change in mentation like lethargy, hypotonia, convulsion are very important information to check whether the baby is critically sick or there is a problem. If these signs are present, then it might show that the baby might have infection, so timely evaluation will be there. Next. So let's go to the thermal care. What should be the management of hypothermia? Assessing a baby's temperature without thermometer is possible. Just by touching the feet and comparing it to the abdomen. If the feet are colder than the abdomen, the baby has cold stress and the baby needs to be warmed. So if you teach this simple method for parents, they can easily detect the problem. And even for the health workers, this is the fastest way of catching any problem. Just by touching the feet and the abdomen, we can detect whether the baby is having hypothermia or not. Next. So when we come to the definition, the World Health Organization defines neonatal hypothermia as an auxiliary temperature below 36.5 degrees centigrade or 97.7 degrees Fahrenheit among newborns aged below 28 days. This definition was made by WHO in 1997, almost 27 years back. And the normal auxiliary temperature is between 36.5 to 37.5 degrees Celsius. Next. In one of the SIP study, which was made in Ethiopia in 2016 to 2018, this study was done in 5 teaching hospitals, and 3,852 preterm babies were included. And the prevalence of hypothermia in newborn, the impact on the survival was studied, and among these newborns, 28.8% of them were died, and 79.6, almost 80% of them were hypothermic. So when we see the mortality from those, about 40.3% of them were having a temperature between 33 to 34 degrees centigrade, and those who have less than 33 degrees centigrade, 60% of them were died. So this shows that the mortality is increasing when the temperature is below 34 degrees centigrade. Next. When we see the risk factor, newborns are mainly predisposed to hypothermia, especially those who have got low birth weight, IUGR, those who had resuscitation and congenital abdominal defect are predisposed to hypothermia. And low delivery room temperature which we found in almost all delivery wards. And if the baby is not drying timely, after post-delivery, then they will be exposed to hypothermia. Bathing the baby after birth and removing the vernix caseosa, also one predisposing factor. And if the baby is not put on skin-to-skin contact immediately after delivery, again, it's also a predisposing factor. And of course, delay initiation of breastfeeding, which we see in most of our delivery ward, is also one risk factor. Next. So situation which increases the risk factor are poor understanding of the healthcare providers about the physiology of thermoregulation. And during neonatal transportation, this is again another area, and procedure-related exposures during surgery, IV placement, and radiological investigation. Babies are exposed to, they stay naked for several minutes, and with this, they can be exposed to hypothermia. Next. When we see the outcome of neonatal hypothermia, neonatal hypothermia is an independent risk factor for neonatal mortality across all gestational age, as many studies are showing. Mortality increased by 28% per 1 degree centigrade decrease in temperature below the normal values. Neonatal hypothermia on admission to NICU has also been consistently associated with intravascular hemorrhage, bronchopulmonary dysplasia. At admission, temperature may not be corrected very fast in many neonatal ICUs. At times, they can stay in hypothermic state for more than 12 hours. So this leads to many complications as well. Next. When we see the mechanism of heat loss, radiation, with radiation, there is no physical contact between the cold object and the baby, but heat is irradiating from the baby to the cold object and from the cold object to the baby. The second one is convection. If in the delivery ward, if the window is open, the door are open usually, so moving air can make the baby cold. So covering the baby is very important. And the third one is evaporation. If the baby is wet and not covered, then the baby will lose a lot of heat. The fourth one is conduction. It occurs if you put the baby in a cold table or a mattress, then the heat will be moving. The heat will go from the baby to the cold table, and the cold temperature from the table to the baby. So all these four condition has to be corrected. In the first 10 to 20 minutes, without any protection, temperature can fall by 2 to 4 degrees centigrade, which is very dangerous, and the baby can develop severe hypothermia within 10 to 20 minutes. Next. Why our babies are prone to hypothermia, especially in the delivery ward? Small babies lose heat easily because they have a large surface area in relation to the weight, especially preterm babies, have larger head, have skin permeable to heat, have little or no subcutaneous fat, especially preterm babies don't have this subcutaneous fat, and they easily get hypothermia, and they are unable to curl up to reduce heat loss. They cannot move around to generate heat. They cannot shiver, And usually in the delivery ward, they are wait and necked for several minutes. So these are the area why the babies are developing hypothermia very easily. Next. When we see the effect of hypothermia on the respiratory system, when the temperature is low, the blood vessel will be constricted, and the blood that goes to the lung and different organ will be compromised. If the perfusion is very low in the lung, then the surfactant production will be affected and the RDS will be worsening. And usually they use their energy, the glucose, to conserve their heat, and they easily deplete the glycogen store in the liver will be depleted very easily, and they develop hypoglycemia. Especially preterm babies don't have glycogen store in the liver that like the term babies, so the preterm babies develop hypoglycemia very easily. And bleeding, they can develop bleeding, disseminated intravascular coagulation, and shock following hypothermia. And all these conditions, if not corrected timely, the baby can die. And as you see, hypothermia is not just a number, it affects the whole system and organ, and it can lead to death. So we need to be cautious to prevent hypothermia. Next. So in order to avoid all this kind of complication, there should be a warm chain that all health workers should accept and implement in the respective area. In the delivery ward, the temperature of the delivery ward should not be less than 25 degrees centigrade. And the window and the door has to be closed. Immediately after delivery, the baby has to be dry, and immediately the baby has to be skin-to-skin contact on the mother, and delay cord clamping also contribute for, it will prevent also hypothermia. And immediately after cutting the cord, the baby should be moved to the chest, and breastfeeding should be provided. And in the delivery ward or in the neonatal ICU, bathing should not be allowed at all. And appropriate choice for bedding, clothing, KMC should be done, and the mother and the baby should be together so that feeding can be initiated immediately. The other area where newborns are exposed to hypothermia is during transportation. So either transportation incubator or skin to skin has to be done, and during resuscitation, it should be done under radiant warmer. In order to implement all these recommendations, health workers should be trained, and they have to be aware of the complication and the conditions as well. Next. For prevention of hypothermia during transportation, let the temperature stabilize before transporting the baby. After correction of the hypothermia, you can transport. A stable, especially term infant, can be wrapped in warm blanket and cup, and they can be transferred. Kangaroo mother care is a good alternative for neonatal transport, especially for preterm babies. For sick infant, transport in heated incubator is a preferred method from delivery room to the NICU, or from one hospital to another hospital. This is a better way of transferring. Next. Next. Okay. When we come to the prevention of hypothermia during stabilization and transportation for those who are less than 32 weeks of gestation, applying plastic wrap without traditional drying reduce the drop-off in body temperature by at least 1 degree centigrade in low birth weight infants. No need to dry the baby immediately. We need to wrap them with plastic sheet. The combined use of plastic bag with radiant heat reduce evaporation and convection process. During resuscitation, WHO recommends keeping infant warm using warm surface and wrap them with plastic bag is the alternative way. You can see it on WHO guideline in 2022. And of course, early initiation, as usual, is one of the important area we should focus. Next. Prevention of hypothermia in the NICU, implementation of KMC, like immediate KMC or intermittent KMC in the NICU, regardless of gestational age and weight, reduce neonatal hypothermia significantly. For those who have started implementing immediate KMC, that's the best one. But for those who cannot do immediate KMC, intermittent KMC is also very important while the baby is having CPAP, IV fluid, and the likes. Use a servo control warmer or incubator if mom is not around. On discharge from NICU, both the abdomen and feet should feel warm normally, and health workers should give an emphasis for this issue. Next. When we come to the management of mild and moderate hypothermia is almost the same. In the first place, we need warm room, bed, and use warm blanket and cap to cover the baby. And kangaroo mother care is the best way of managing mild and moderate hypothermia. If baby is still cold while in KMC, put an additional cover or give a hot ring to the mother. And early initiation of feeding also has got a great impact on managing mild and moderate hypothermia. Next. When we come to the management of severe hypothermia, all newborns with severe hypothermia should be admitted and rewarmed in the incubator or under radiant warmer. Remove all the clothes while rewarming in an open care radiant warmer. The temperature is set to 36.5 degrees C to bring the temperature to a normal range. Measurement different between more than 2 to 3 degrees centigrade between the core and peripheral temperature is abnormal, so we should look for the causes and try to manage. Those who are having severe hypothermia may need additional supportive management, like if the baby is having respiratory distress, especially for those less than 32 weeks, CPAP is recommended by WHO. Blood sugar determination is very important, as hypoglycemia is one of the complications. IV fluid may be needed, and appropriate monitoring of vital signs is very important, very frequently in the first few hours of life, or they have to be on continuous monitoring. Next. In summary, newborn babies become cold very easily. Small preterm babies are even more vulnerable. Hypothermia can make babies ill or worsen existing illness. Hypothermia or unstable temperature may be a sign of infection. Mortality increased by 28% per 1 degree centigrade decrease in temperature below the normal temperature. And skin to skin is the best care for preventing and managing hypothermia. So prevention is the best way to avoid deaths and complications related with hypothermia. These are our references, and thank you.
Thank you, Ms. Asrat.
Thank you.
Can I ask
Thank
a
you.
question?
Okay.
Please go ahead.
Ms. Asrat, you have told us management of severe hypothermia. Can you please explain if a baby is found to be temperature of 32 Celsius, then in how much time the baby will be reach the normal temperature that like the 36.5? In how much time, and what is the rate of rise of temperature in a baby with hypothermia? Can you please explain that?
Thank you. If the baby is severely hypothermic, then the baby needs fast. The hypothermia has to be corrected very fast, and every 1 hour the temperature has to rise by 1 degree centigrade. Until the temperature of the baby is equivalent to 34 degrees centigrade, then slow warming can be introduced. You can increase the temperature by you can for the fast rewarming by the temperature has to rise by 1 degree centigrade every 30 minutes. Then after the temperature is 34 degrees centigrade, the temperature has to rise by 1 degree centigrade in 1 hour. Initially, we need a fast rewarming till the temperature is 34 degrees centigrade.
Thank you.
Thank you, Dr. Asrat. So if you have a question, you can still raise your hand while you connect to our traditional quiz. So we have the instructions. You can just scan the QR code or go to Menti, and this is the code. I'm going to type this in the chat. So I will be waiting for your connections. We have, you can do a like so we know that you are being connected. If you have any connection issue, please inform. So I'll try to help you. And if you have any question, meanwhile, for Dr. Asrat, please raise your hand. Beautiful. I have a connection starting. Okay. So if you cannot connect, you will be able to still answer. You can use the chat and you can answer through the chat. So let's start. We can join the quiz. You can just choose a name. It doesn't have to be your real name. It can be pseudonym. The quiz is anonymous, so we'll not know who answered, but you can also use a name if you prefer. Okay, we have 9 players. You can still connect in the middle if you cannot connect in the beginning, but you probably have less points. Okay, so let's go. Okay, so what's the normal range of axillary temperature for a newborn? This is just to get warm, literally. Okay, interesting. Okay, good one. So we have most of the participants who answered the 36.5 to 37.5, which is the right answer. One participant answered 35.5 to 36.5. Just as a reminder, this would be already in the range of mild hypothermia, as Dr. Asrat has shown on her presentation. We'll maybe come back to the slides. Okay. So normal range, 36 to 37.5, and then between 36.5 and 36, we'll start in this mild hypothermia range with cold stress. So this is already something that's abnormal, and then here we already have to take some action. Dr. Asrat, would you like to add something?
No.
Okay. Okay, next question. Get ready. I think we lost some people. Ah, they're coming. Okay. Just a little bit. Keep your phone with you. That's good. Have more players now. 10 players. Amazing. Okay, let's go. Okay. What is the first sign that a neonate is starting to feel cold? Okay, his thorax is cold, his front is cold, his hands and feet are cold, or the baby starts shivering, shaking. Perfect. So we have all the right answers. Dr. Asrat, would you like to comment?
I don't have any comment. They did well.
They did well. They did very well. That's perfect. Just as a reminder, neonates, they don't shiver. The full-term neonates, they do what we call a non-shivering thermogenesis. So no neonate can shiver. So you never see this. Okay, next one. Let's get ready. It's going to get a little bit more complex. Okay, everybody's ready? Okay, which of these steps is not important for thermal care before delivery? What is not important? So it's the wrong one, okay? Warm the delivery room between 25 and 28, close the doors and windows, prepare warm cloth, turn on radiant warmer, or prepare antibiotics. Okay, that's also a good one.
They did it very fast.
Very fast.
They did
I forgot to say you only have 15 seconds. Okay, let's continue playing. Next one. Hope I didn't jump one question. Okay, so okay, I forgot. I lost one question, so I'm just going to go back. I'm a little bit. Okay. Okay, this one. Okay, so you have a baby that's born at 33 weeks, and he is fine and he's well. And what do you do before transfer to SNCU? You put the baby on skin-to-skin care, you put the baby on skin-to-skin care and an incubator if the mother is not available, or both are correct. Good one. Both are correct. This was very fast also. So the idea is that a neonatal transport can be done on skin-to-skin care or in an incubator if babies are unstable, and they can be transferred on an incubator. But if there is no incubator and the mother is available, skin-to-skin care, it's an amazing transportation incubator. Okay. So you have this baby, it's 33 weeks, and he's on CPAP. He has respiratory distress, he's on oxygen, and he's on a radiant warmer. How often you're going to monitor this baby in the SNCU? Perfect. So the baby, it's a 33 weeks baby who is unstable, or it's very sick. He's stable actually, but he's very sick. He has respiratory distress, he's oxygen dependent. So continuous monitoring, if possible, is indicated. Temperature should be measured regularly, and if you have a probe attached to radiant warmer or to incubator, it would be even better. That's very good. So what's the primary goal finally for thermal care of the newborns? Maintain the body temperature of the newborn, prevent hypothermia, or treat hypothermia? You can answer two different ones here. That's great. So these two ones are correct because maintaining body temperature is also preventing hypothermia. So if you maintain the correct body temperature, of course, if the body temperature is not right, we should not maintain it. We should do something. And the main goal of thermal care in the newborns is to keep the thermal neutral zone and prevent hypothermia. That's perfect. So this one, you can take some time. You can scroll your finger through the screen to have your answer. So you can just scroll and should say if you agree or if you don't agree. You can also stop in the middle. KMC is the preferred method to prevent hypothermia in preterm babies. To prevent hypothermia. To treat mild hypothermia in KMC is the best method. Incubators and radiant warmers are not needed for sick preterms when the mother is not available. To treat severe or refractory hypothermia, a radiant warmer is needed. So you can say if you agree, if you don't agree. And if you agree, actually, you're going to stay here. If you strongly agree, you can also be in the middle. Yeah. Okay. There are some still answers going on. That's very nice. Interesting. Would you like to comment, Dr. Asrat? To start commenting?
They're doing good. Happy.
You maybe start from each statement. So here we have 2.1. So most of the people, they agree that KMC is the preferred method to prevent hypothermia in preterm babies. I cannot see if there are hands. Let me see if there is any hand. Oh, you also have answers in the chat. That's amazing. So I have some for this new one. Agree, agree, disagree, and agree. That's nice. Thank you, Dr. Shamin. We have a hand. Ayobami.
Oh,
Sorry. Would you like to ask a question?
Yes.
Yes, please go ahead.
Hi. Hello?
Yes, we can hear you.
About the last question. I didn't get the last question you asked.
This one to treat severe or refractory hypothermia, a radiant warmer is needed. This one?
Yes, it's needed.
Yeah.
Hello?
Yes, I can hear you. Yeah.
Yes, it's
Yes.
needed.
Yes, because here the idea, when you're talking about severe hypothermia, we're talking about very severe, so less than 32 degrees. So we need a very fast warming in the beginning, as Dr. Asrat was explaining. So it's the best way is to give an external source of heat, which can be a radiant warmer, which can also be an incubator, but the radiant warmers usually they are even faster on the rewarming. So a radiant warmer, it's preferred for severe if there is a presence of a radiant warmer. Otherwise, it's also going to be KMC with warming the baby and the mother and covering and trying to warm. But if you have less than 32 degrees, it's better to start with a method that is warming from the outside and then warm slower, and which can be done in also KMC.
Yeah, in severe cases, KMC alone is not a preferred way to manage severe hypothermia because we need to correct the hypothermia very fast and timely. So radiant warmer is needed. If the radiant warmer is not adequate, then warm mattress has to be applied below the baby. And at times you can also cover the baby from the top with plastic sheet. Even radiant warmer may not be adequate in severe cases. Thank you.
Thank you.
Thank you. So that's very good. Incubators. So let's go statement by statement. KMC is the preferred method to prevent hypothermia in preterm babies, which most of the people agree. And I think we can all say that we agree, especially if you have stable babies, but also babies that are on respiratory support and that are more sick, they also can do KMC, and this also prevent hypothermia. So this is a very, very good method, not only for hypothermia. To treat mild hypothermia, KMC is the best method. So definitely, if the baby is starting to get cold and he's not under thermal support, the best way is to put the baby on the skin of the mother. It can also cover the baby and put a head and cover the extremities. Incubators and radiant warmers are not needed for a sick preterms when mother is not available. So most of the people, they do not agree. And it's true that you need some external source of heat for sick babies that are very small, especially smaller than 2 kilos, when the mother is not available, because these babies, they will tend to lose more heat and they will not produce heat as easily as big ones. So definitely you need either the mother, either a surrogate, either an external source of heat. And to treat severe refractory, well, we already treated this one. Go to the next. We're arriving to the end. Let's get ready. The next one is easier, simpler, but you have to be fast. So we have 15 seconds. I will just open the chat, so if maybe we have some things coming. Let's go. Which of the following gets worse with hypothermia? Oxygen consumption and respiratory distress, glucose consumption, and risk of, it's hypoglycemia there. And both of these are correct. So with hypothermia, yes, good one. Thank you. This one was to be a very fast wake up at lunchtime, after lunchtime. So both are correct. So when you have hypothermia, actually temperature is energy. So it's thermal energy. So when you need to produce more energy, to produce more temperature, you need to have more sugar, because sugar is part of the energy process, and you also need more oxygen. So babies that are on distress, on stress, on thermal stress, because they need to conserve their temperature or to increase their temperature, they will consume, they'll have a higher consumption of oxygen, and then the respiratory system is going to pay. And also they will have a higher consumption of sugar, of glucose. And that's why we can have hypoglycemia with hypothermia, because they are having more consumption to keep normal or to increase their temperature. And it's the end, the winner. It's calculating, so it's also based on your, it's the hustler. So congratulations to the hustler. I don't know who is it. If you want to review yourself, you're welcome. Otherwise, congratulations, and congratulations to everyone that participated on this quiz. We still have some time.
They can post their name. Let's know who is he.
You can show your name if you want, the winner. It's also good. And otherwise, thank you also for the people who took participation in the chat. A lot of people answered the questions there, so it's very good. Very good. Is there any other comments? Any question from the audience? I have seen many people active in the chat also. Maybe if you have any question or comments, things to add. I have Suman who put her video. Would you like to say some words, Suman?
Yes, I think it was great, Asrat. Very, very, such a calm and emphatic presentation. Thank you very much. And I'm sure people who have joined have benefited well. And more importantly, I would like to say that this is going to be on the YouTube channel. It will be available for all your healthcare providers who could not participate. We would also like to know how many healthcare providers have come for this seminar, because I do recognize a lot of mentors. Thank you for coming here, and research people, but it would be good to know whether there are people from the sites who have come. So a request for people to write their names, or maybe you can raise your virtual hand so that we have some idea. Today, I think it's been a little on the lower side. The participation has been around 30 maximum, but I do hope that more people can see it. Just one feedback I would like to give for all of them. We are looking at data which is coming in from the sites, and hypothermia incidence and hypoglycemia incidence is very varied. So one request is to first start monitoring. Unless we know how big the problem is, we will not be able to prevent it. So monitoring is very important in all the sites where we are taking care of small babies. Frequent monitoring, at least 2 to 3 hourly if they are sick, and 4 to 6 hourly even if they are not sick, of these small babies is vital. And when we do the monitoring, whether it's temperature monitoring or sugar monitoring, we are likely to find these issues. If any of us say, I don't have hypothermia in my unit at all, we know that they're not monitoring well, because hypothermia is a problem in all our units. Sometimes when mothers take the baby from a radiant warmer just for holding and feeding and they've not covered well, hypothermia can occur. So that's one thing about monitoring. And the second issue that we are finding is that kangaroo mother care, which actually started off as a tool to maintain temperature 50 years ago, it has found various other benefits, but it's one of the big incidents, one of the big protectors it has is against hypothermia. And we find the use of kangaroo mother care across the sites quite low. So that's something that we would like you to embrace. Use kangaroo mother care as a tool to care for babies because it has so many benefits, and we'll have another seminar on it. But it's also a great tool to prevent hypothermia and to treat hypothermia. Even for a term baby, a good weight baby, if you have hypothermia, you can put the baby in skin to skin contact and try to address this hypothermia. So those are the 2 points: monitor and use kangaroo mother care, because all the aspects of care of the baby, whether it's hypoglycemia, hypothermia, sepsis, kangaroo mother care can be one answer to all these problems. Thank you.
Thank you so much.
Dr. Asrat, would you like
Yes.
to leave a final message, please?
Yeah, someone already mentioned it, health professionals are not aware of hypothermia and the grave complications of hypothermia. We don't understand. So maybe this presentation may help them to give more emphasis for hypothermia. If we prevent hypothermia, I'm sure our survival will get improved significantly. Most of our patients are having sepsis, severe RDS, maybe because of the hypothermia. If we prevent hypothermia, I'm sure all this complication may decrease in the future. Thank you.
Thank you, Dr. Asrat.
Yeah.
Okay. Thank you, everyone. I just shared with you the flyer for the SSNC multi-country seminars. So next one is going to happen in the next 2 weeks. It's going to be IV fluids and IPC. It's going to be the Pakistani team. And you all have received the flyer and the links, but if you don't have, please write and we can send it to you again. We will be waiting to see your teams. Right after this presentation, I'll be sharing the link for the YouTube presentation. We have our channel, so I'll also be sharing this with you. And you can all follow the previous presentations and this one with your team. So thank you very much. Thank you, Dr. Asrat. It was a pleasure to work with you.
May I just come in a photo for us? Please put on your video so that we can capture this beautiful moment together. It's a pleasure to see you all again, and yeah, wonderful. Yeah, I think many others may not. Lovely to see Ade, Sharmeen, so many of you all, Alfor. The others have not put on their videos. Dilbar, Muhammad, very nice. Thanks, Sabrina. Thank you all. Thank you all very much for participating actively, and we look forward to the next one. Thank you so much, Flavia. Your mentees are a big success.
Thank you, Flavia.
Thank you,
everyone.
Asrat. Bye.
Thank you. Thank you.
Thank you.
Thank you. Goodbye.
Thank you.